Bismillahirrahmanirrahim. We start today's proceedings with recitation of Quran. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. واضرب لهم مثل الحياة الدنيا كماء أنزلناه من السماء فاختلط به نبات الأرض فأصبح هشيما تذروه الرياح وكان الله على كل شيء مقتدرا. المال والبنون زينة الحياة الدنيا والباقيات الصالحات خير من عند ربك ثوابا وخير أملا. ويوم نسير الجبال وترى الأرض بارزة وحشرناهم فلم نغادر منهم أحدا وعرضوا على ربك صفا لقد جئتمونا كما خلقناكم أول مرة بل زعمتم أن لن نجعل لكم موعدا. ووضع الكتاب فترى المجرمين مشفقين مما فيه ويقولون يا ويلتنا ما لهذا الكتاب لا يغادر صغيرة ولا كبيرة إلا أحصاها ووجدوا ما عملوا حاضرا ولا يظلم ربك أحدا. صدق الله العظيم. ये सूरह काफ की पांचवें रुकू की आयत हैं। जैसे मैंने एक दिन पहले भी अर्ज किया था कि कुरान पाक की ऐसी सूरत है जिसमें अल्लाह पाक ने दुनिया की हकीकत को बहुत वाज़ेह फरमाया है और दजाली फितना के लिए इसका जुमे के दिन पढ़ना अफजल है। तो इस रुकू में भी पहले रुकू वाला और आखिरी रुकू वाला मजमून है वज़रिब लहुम मसलल हयात दुनिया, सेट फोर्थ टू देम the similitude of the life of this world. Kama in anzalnahu minas samai fakhtalata bihi nabatul ardh. It is like the rain which we send down from the skies. The earth's vegetation absorbs it. Fasbaha hashiman tazruhu riya. The earth's vegetation absorbs it, but soon it becomes dry stubble. وَكَانَ اللَّهُ عَلَى كُلِّ شَيْءٍ مُقْتَدِرًا, which the winds do scatter. It's only Allah who prevails over all the things. Al-malu wal-banuna zinatul hayatid dunya. Wealth and sons are allurements of the life of this world. Wal-baqiyatu salihat, but the things that endure are good deeds. Khayrun inda rabbika sawaban wa khayrun amala. Good deeds are the best in the sight of the Lord as rewards, and best as the foundation for hopes. وَيَوْمَ نُسَيِّرُ الْجِبَالَ وَتَرَى الْأَرْضَ بَارِزَةً. One day we shall remove the mountains, and thou wilt see the earth as a level stretch. وَتَرَى الْأَرْضَ بَارِزَةً وَحَشَرْنَاهُمْ فَلَمْ نُغَادِرْ مِنْهُمْ أَحَدًا. And we shall gather them all together, or shall we leave out any of them? Nor shall we leave out any of them. وَعُرِضُوا عَلَى رَبِّكَ صَفًّا, and they will be marshaled before thy Lord in ranks. لَقَدْ جِئْتُمُونَا كَمَا خَلَقْنَاكُمْ أَوَّلَ مَرَّةٍ. with the announcement, now have ye come to us where as we created you first. Bal za'amtum allan naj'ala lakum maw'ida. Hey, you thought we shall not fulfill the appointment made to you to meet. وَوُضِعَ الْكِتَابُ فَتَرَى الْمُجْرِمِينَ مُشْفِقِينَ مِمَّا فِيهِ. And the book of deeds will be placed before you, and thou wilt see the sinful in great terror. وَيَقُولُونَ يَا وَيْلَتَنَا مَا لِهَذَا الْكِتَابِ لَا يُغَادِرُ صَغِيرَةً وَلَا كَبِيرَةً إِلَّا أَحْصَاهَا. Because of what is recorded therein, they will say, ah, woe to us, what a book is this? It leaves out nothing small or great. وَوَجَدُوا مَا عَمِلُوا حَاضِرًا. But takes account thereof. They will find all that they did placed before them. وَلَا يَظْلِمُ رَبُّكَ أَحَدًا. And not one will thy Lord treat with injustice. ए नबी, उन्हें हयाती दुनिया की हकीकत इस मिसाल से समझाएं कि आज हमने आसमान से पानी बरसा दिया तो जमीन की पौध खूब घनी हो गई और कल वही नबातात भुस बनकर रह गई जिसे हवाएं उड़ाए फिरती हैं। अल्लाह ताला हर चीज पर कादिर है। ये मिसाल आखिरत की मिसाल को समझाने के लिए और हयात बादुल मौत का के तस्वुर का यकीन दिलाने के लिए है कि जो अल्लाह पाक पानी को बरसाकर मुर्दा जमीन में जान डाल सकता है और इस साइकिल को बेशुमार मर्तबा रिपीट कर सकता है, वो ह्यूमन साइकिल को भी रिपीट करने पर कादिर है। जिसने तुम्हें पहली मर्तबा पैदा किया वो दोबारा भी पैदा करेगा। ये माल और ये औलाद महज दुनियावी जिंदगी की एक हंगामी आराइश हैं, असल में तो बाकी रह जाने वाली नेकियां हैं। तेरे रब के नजदीक नतीजे के लिहाज से बेहतर हैं और वही नेकियां ऐसी चीज हैं जिस पे उम्मीद रखनी चाहिए कि हमारा रब उनकी वजह से हमें मुआफ फरमाएगा। और उस दिन की फिक्र करनी चाहिए जिस दिन पहाड़ों को चलाया जाएगा और तुम जमीन को बिल्कुल बरहना और हमवार पाओगे। इसकी सारी ऊंचाइयां और सारी गहराइयां बराबर कर दी जाएंगी और फिर तमाम इंसानों को घेर कर जमा कर लेंगे और उनमें से कोई एक भी नहीं छूटेगा। वाउरीजु अला रब्बिका सफ़ा, और सब के सब तुम्हारे रब के हुजूर सफ़े बांध कर पेश कर दिए जाएंगे और ऐलान होगा कि आ गए ना तुम हमारे पास। लक़द जितुमूना कमा खलक़नाकुम अव्वला मर्रा, देखो हमने तुम्हें वैसे ही पैदा कर दिया जैसे पहली मर्तबा किया था। बल ज़अमतुम अल्लन नजअल लकुम मौइदा, हालांकि तुम्हारा ये गुमान था कि हम मुकर्रर दिन पे तुम्हें इकट्ठा नहीं करेंगे। ववुदिअल किताबु फतरल मुजरिमीना मुशफिकीना मिम्मा फी, और नामा अमाल सामने रख दिया जाएगा और तुम देखोगे कि मुजरिम लोग अपने किताबे जिंदगी के अंदराजात से खौफजदा होंगे। वयक़ूलून या वैलतना मा लिहाज़िल किताबि ला युगादिरु सगीरतन वला कबीरतन इल्ला अहसाहा, और कहेंगे हाय हमारी बर्बादी, ये कैसी किताब है, ना किसी छोटी बात को छोड़ती है ना बड़ी बात को, हर चीज का अहाता किए हुए है और अपने तमाम अमाल को अपने सामने हाजिर पाएंगे और तुम्हारा रब किसी के ऊपर जुल्म नहीं करेगा, फैसला इंसाफ से करेगा। अल्लाह पाक हमें मरने से पहले इस दुनिया की हकीकत को समझने और आखिरत की तैयारी की तौफीक अता फरमाए और ऐसे अमाल करने की तौफीक अता फरमाए कि जब हम दुनिया से जाएं तो हमसे राजी हो। वमा अलैना इल्लल बलाग। Today's discussion is about nuclear dislocation and subluxations in phaco-cataract surgery. As we already know it, that we started our discussion with discussion on phaco basics, and then there were advanced phaco in difficult cataracts, followed by complications of phaco surgery. And this is the third discussion on complications of phaco surgery. In first discussion, we reviewed overall complications and their management. And in the second discussion on last Thursday, we had a discussion on capsular complication and anterior vitrectomy techniques. And today's lecture in this Phaco course, which is being conducted through coordination of Eye Acuity Education Portal, Eye Department Jinnah Hospital Lahore, Eye Department Wabda Teaching Hospital Complex Lahore, and its online transmission and record, and the replays are available through courtesy and sponsorship of Optimus Pakistan, who are the importers of Swiss Advanced VN IDO IOLs with the name of Lucidus IOLs. So we are thankful to them who made this breakthrough and a kind of landmark in our national ophthalmology, that is conduction of and presence of webinars. It is first time in our history of ophthalmology in Pakistan. So we are thankful to our sponsors, and we are thankful to Professor Nadeem Hafiz Bhatt for leading this webinar all the way through. And in today's discussion, we will be reviewing the overall nuclear complications during phaco-cataract surgery, and then their prevention and management. And as usual, we will have few videos to discuss and to comment with live demonstration of nuclear complications management. And in the end, we will be reviewing the course and concluding. And by the completion of this course, we hope our participants should be able to anticipate, prevent, and plan a surgical intervention when faced with a nuclear complication during phaco-cataract surgery. Classify and describe different clinical presentations and appropriate surgical technique for primary and secondary management of nuclear complications. Understand the surgical procedures involving safe outcomes after a nucleus dislocation in phaco-cataract surgery. So complications which can occur during the management of nucleus, as I always say, the whole concept of phacoemulsification is aimed at safe emulsification of the nucleus. And that's where you are going to use high energy oscillating phacotip to safely emulsify the nucleus inside the capsular bag. And that's where the more drastic complications can occur. So the vitreous loss may occur, and the whole procedure maybe need to convert it to intracapsular cataract extraction. Posterior dislocation of the nucleus may occur after anterior successful completion of the anterior capsulotomy. The hydrodissection may be overzealous, or we may not be knowing the kind of relationship or pathophysiology which that particular cataract had. That is posterior corticocapsular adhesions, and a simple hydrodissection wave may dehisce the capsule and the nucleus may descend in the vitreous cavity. And then there may be some pre-compromised zonules which may lead to nuclear dislocation. And tears of the posterior capsule may occur at different stages, as we will see in the following slides. And the nucleus may be dislocated in vitreous cavity. And there may be inadvertent iridodylisis as well, because the surgeon becomes tense. And if the complication occurs, it invites other complications. That's why it is important to get well versed with tips and techniques to manage difficult situations. And then inadvertent damage to corneal endothelium may occur because we are unable to control the damage. So if the complication occurs, the damage control and your response becomes even more important. So at what stage the nucleus may dislocate? It may dislocate during hydrodissection. That is some pocket formation behind the nucleus because of the blocked outflow. The wave doesn't pass. There is accumulation of the fluid behind the nucleus and it ruptures the capsule. Or there may be some inherent weakness. And we know by our anatomical knowledge. There is a question in FCPS. What is the thinnest part of lens capsule? Posterior pole is the thinnest part of posterior capsule. And it may be already compromised. There may be some inherent coloboma or some embryological defect which may gush and the capsule may rent. Then the capsule may get compromised and nucleus may dislocate during rotation of the nucleus. And while we are trenching, as we discussed in previous discussion, the buttonhole sign, there is a punched piece where the red glow starts coming and it appears as if there is no cortex left. That is too deep sculpting, too deep trenching. And as I mentioned, while preparing the trench and sculpting, one needs to be very careful regarding dragging of the nucleus, because for the beginning phaco surgeons, there is a tendency that we apply too much force while our phaco needle is moving on the anterior surface of the nucleus. We need to remember that very little force is required from incision towards the opposite direction. Actually, the needle need to use phaco force to keep on creating the trench and then move. So that's very important for beginner phaco surgeons, that there should be no mechanical stretch on the nucleus that will compromise the zonules. And during phaco chop, as usual, there may be extra stress on the zonules. And if hydrodissection is incomplete, that can also result that at the same time, because the nucleus is not separated, at the same time the capsule is torn. So hydrodissection becomes very important. As long as the initial phase of dreadful complication of nucleus is concerned, hydrodissection is the most important maneuver. And as I mentioned many times, right from basics to difficult cataract phaco, multi-quadrantic, incremental hydrodissection. And then the complication may also occur. We have divided the nucleus and now we are emulsifying, especially towards the last stage. Once there is no cortical sheet left behind to provide a cushion to the capsule, I always advise that provide cushion there with your non-dominant hand. Take your second instrument under the phaco tip so that if there is surge, your capsule remains protected. So at any given stage, the complication may occur. So if the nucleus drops or the capsule is rented, what will happen? It can give rise to very severe vitritis. Your own nucleus, your own lens is taken as a foreign body, a foreign protein inside of your eye, and there is a kind of anaphylactic reaction, very severe vitritis. The vision will be, of course, decreased. There may be redness and pain. There will be ciliary congestion, corneal edema. And amazingly, this is how the humans differ. And this is what makes the life of a doctor difficult, because this is biology. These are humans. They differ in their response. They differ in their hypersensitivity reactions. Sometimes the whole nucleus may be there and the eye is as quiet as nothing has occurred. And the patient is able to see with +10 pinhole till last line. And sometimes you are just unable to control the intraocular pressure and vitritis with any means. And you need to intervene within 24 to 48 hours. The eye will not get quiet until you get rid of the dislocated nucleus. The IOP may be normal or may be raised, but the more often it is raised. And it also depends on the amount of nucleus which has descended or dislocated into the vitreous. The lesser, if it is less than 25%, less reaction is expected. More than 25% of the nucleus is dislocated, more reaction is expected. So what are the risk factors? If we know them, probably we can prevent this complication to occur. In history, Professor Wasif Marhoom used to say that always look if there was any complication in other surgery. The cataract is very good. It is 2+ nuclear sclerosis. There are no other risk factors, but somehow there was a rent in the previous eye. So that tells you that this patient may be having some inherent issue which predisposes this patient to this complication more than a patient who has a successful phaco-cataract surgery in other eye. And the second thing, knowing the history of other eye makes us more careful. If the patient already had a complicated cataract surgery in one eye, probably deserves more attention and more care so that we are able to give a successful phaco surgery in this eye. In clinical examination, hard cataract, total cataract, traumatic cataract, subluxated lens, small pupil, vitrectomized eye, pseudoexfoliation, proptosis, high myopia, eyelid abnormalities like shortening of the palpebral fissure, proptosis, patients with short, thick neck, and obesity are all prone to higher incidence of nuclear dislocations. So by the way, what's the incidence of nuclear dislocation in phaco-cataract surgery? It's about 1 in 1,000 or 1 in 2,000. Recently, it has decreased. We will see later on together. Inexperienced surgeon is more prone to get this catastrophe. Topical anesthesia in uncooperative patient, radial tears in rhexis, vigorous hydrodissection, inability to judge the depth of the nucleus, the thickness of the nucleus during sculpting. Continued aspiration after fragment removal. That is your hand-feet coordination. That your hands and your eyes must coordinate with your feet. That you should know at what step your foot control is. Immediately after removal or emulsification of the fragment, the moment the phaco tip is no more occluded, you have to come back to position 2 of your foot control so that no more phaco is being applied without an engagement of the nuclear fragment. So that's very important. And at the end of the procedure, we need to be no more euphoric, need to be very careful, as Dr. Naeem said, that through the end of the procedure, we should be more touchy, applying less phaco power, and the moment tip is no more occluded, no more phaco should be delivered in anterior chamber. That will safeguard against many complications. And if we are able to control our foot control properly and we use phaco energy only when it is really indicated, that will not let your phaco tip get heated. The only engagement of the capsule in phaco tip may spare you sometimes if your tip is not heated. It just kisses. If a heated phaco tip just goes near to the capsule, it can just rip it with the heat. So how can you prevent your phaco tip not getting heated? Is by intelligent use of your foot control. That keep on switching between position 1, 2, and 3, realizing at what stage you are inside the anterior chamber. So that realization is very important so that your phaco tip is not heated and you are not using excessive phaco energy, which will not only safeguard corneal endothelium from being damaged, but will also safeguard your posterior capsule. And then it is very important to recognize the complication early. We will be revising few slides here because it is very important to detect the damage, the complication early so that you can immediately react and go towards the damage control instead of complicating it further. What are the signs of PC rupture? Sudden deepening of anterior chamber. There may be momentary pupil dilation or constriction. Sudden transitory appearance of clear red reflex in periphery. Why? Because the vitreous will prolapse and will push the nucleus on the side, and the red reflex will suddenly emerge from that particular peripheral rented place. Newly acquired difficulty to rotate a previously mobile nucleus. Yes, you were doing it very perfectly. The nucleus was obeying you. You were rotating it comfortably. Suddenly, the nucleus refuses to rotate. So that is an early indication of capsular rent. And then it's very obvious if the nucleus starts descending from one side. And there is another very important characteristic which occurs after the rent, that is loss of followability. that you were easily engaging the pieces and getting them emulsified, but suddenly you realize that your vacuum is not able to engage a very free fragment of the nucleus. So be careful. Don't move too much inside the anterior chamber. Just reassess if PC rent has occurred, because loss of fallibility is one of the earliest signs of a capsular compromise and vitreous prolapse. Chances of postoperative issues, inflammation is very high, 70%. Secondary glaucoma occurs in 50% of the cases. Corneal edema occurs less. Retinal detachment in about 2% of the patients, but mostly occurs in the patients which are not managed well. We will see what are the mandatory management principles for anterior segment surgeon. CME chances are increased, and then choroidal effusion chances are also increased. In early recognition, I have included this slide again, that is known as flap rip sign.
The study had to conclude that extended tears that are everted and fluttering are pre-equatorial tears, while anterior capsule tears that are inverted and non-fluttering have a posterior capsule rupture. The everted and fluttering flap would reassure surgeons that the anterior capsular tear is pre-equatorial and safe Phaco can be continued. The surgeon would instantly know and point out safe Phaco when tear extends beyond equator by appearance of non-fluttering and inverted flap. The conversion to extracapsular cataract extraction or to the manual small incision cataract surgery at this stage would prevent all the complications which are associated with posterior capsule rupture classical science. The knowledge of the flap utility sign would help the surgeon to conclusively decide about the safety of intraocular lens implantation in the back. Now, the new surgical gaze of anterior capsule tear would make all the difference in surgical experience in the presence of an anterior capsule tear.
Everyone understands this flap sign. If you have any confusion about it, we can clear it right now. Fluttering flap sign. If it flutters, that shows the tear has not extended beyond equator of the cap lens. If it is no more fluttering and has sort of given way, that shows the tear has extended beyond the equator, and probably we need to convert. A safe Phaco is not possible if the flap is no more fluttering. Other signs of PC rent we saw in our previous discussion as well. The punch sign, there is a small hole in the cortical plate. Probably the capsule has rented beneath that hole. Then we need to understand the use of chopper at the end of the phaco surgery of emulsification of the nucleus, so that we are able to prevent our capsule. We have already discussed the early signs of capsular rent, and loss of fallibility of the lens material is indication of vitreous loss. The anterior hyaloid may be intact, or the vitreous may be in anterior chamber but not in the incision. And in the third stage of vitreous prolapse, the vitreous is there in anterior chamber as well as prolapsing through the incision. So this is how it needs to be identified and taken care of. Because if it is stage 1, the hyoid face is intact, then the ability and the skill of the surgeon to manage this crisis is such that it should not be prolapsing into the anterior chamber, and we should be able to remove the remaining parts of the nucleus and cortex successfully. That is a skill which we need to learn. That at whatever stage we discover that the complication has occurred, it should not go into next stage. Peaked pupil is very important sign of the vitreous prolapse and shows that the vitreous is prolapsing through your incision. And as we discussed previously, the sponge vitrectomy is no more indicated, though we can, without pulling the vitreous, we can use scissors to cut the vitreous tags. But pulling the vitreous and then cutting it with scissors is not recommended because it will cause traction on the retina. Early response, these are the few slides from our previous discussion. That was, don't pull out of the eye when recognizing a complication. The Phaco tape between the lips of the wound controls the intraocular environment. So if you realize that something has gone wrong, you may bring your foot control in position 2 or 1, but don't remove your Phaco tape from anterior chamber. Wait until you are able to inject the viscoelastic with your non-dominant hand or with your other hand into the anterior chamber and maintain the anterior chamber. Don't let it fluctuate in case of complication. After maintaining the anterior chamber, only then remove your Phaco tape from the anterior chamber. And then reassess and categorize at what level of complication you have got. The collapse of the chamber will definitely extend the range and will worsen the situation. And then we advise not to inject injection xylocaine because it can give rise to temporary amaurosis. Anterior vitrectomy techniques we discussed. We can convert the ripped anterior or posterior capsule into a rhexis again, if possible. That will safeguard against many problems. It may be redirected into a rhexis like we perform in cases of pediatric cataract surgery. Then there is a term viscolevitation, that we can use a good quality heavy viscoelastic to provide a cushion beneath the nuclear fragment, and we can use slow motion phaco combined with viscolevitation for emulsification of the nuclear fragments on a rented capsule. And we may need to inject and use this viscolevitation technique multiple times for small fragments. We provide the cushion, we perform a slow motion phaco, we bring another fragment, and we perform the same procedure. You need to be very patient to handle these situations. And if the lens fragment is dislocated below the capsule into the vitreous cavity, the wise thing is to leave it. Don't try to use your instruments or Simcoe cannula currents to push it anteriorly. Remember, the lens materials and the nucleus cannot damage the retina. The wrong manipulation of this material inside the vitreous cavity can damage the retina. So avoid these maneuvers. So if the nucleus drops, what anterior segment surgeon or the surgeon needs to focus on safe management of the vitreous and cleaning of the anterior chamber and the capsular bag, manage the wound, and you can call your senior, or if the fragment has gone posteriorly, you may ask the help of a vitreoretinal surgeon. The timing of the deep vitrectomy or pars-plana vitrectomy or removal of the nucleus, the ideal time is between 2 to 4 weeks. Less than 4 weeks give rise to more than 4 weeks give rise to more retinal complications, and less than 2 weeks the cortex is not emulsified, the PVD has not occurred. So our tendency is to do it between 2 to 4 weeks if there is no severe vitritis or acute rise of intraocular pressure. If there is acute rise of intraocular pressure and very severe vitritis, and then we have to watch for the corneal clarity as well. And that is important, that your excessive manipulations may compromise the corneal endothelium. What you need to realize is that you have to preserve as much corneal endothelium for a secondary procedure as possible, and you have to preserve as much of the capsule, anterior or posterior, for a secondary placement. So that's what you need to keep in your mind, that you have to leave cornea clear and you have to preserve as much as of the capsule as possible for secondary placement of the intraocular lens. And at the same time, you have to give as clear anterior chamber and bag of the remnants of the lens matter as possible. That's the art which needs to be learned and understood in cases of nuclear complications, that we have to provide a clear anterior segment with a clear cornea and as much of the capsule as possible for secondary intervention successfully. So management can be done either with PPV, can be combined with in toto delivery of the nucleus. You bring it in the anterior chamber and then remove it, or you can perform a Phaco fragmentation. It again depends on the nuclear sclerosis and the size of the fragment itself. Sometimes you are able to remove it just with the cutter. Sometimes you need to use perfluorocarbon liquid, and you can perform Phaco fragmentation on the surface of perfluorocarbon. And sometimes you can use endoscopic techniques as well. If the cornea is too much compromised, then you may need endoscopic vitrectomy to remove the nucleus. Then you perform the pars-plana vitrectomy, you clear the nucleus, you complete the PVD, remove the vitreous, and then you bring the nucleus with some suction technique or endocrioprobe in the anterior chamber, and then you have already prepared an incision, and you take your viovectus or iris depositor behind the nucleus, and you need to pull it out. In these cases, the standard technique of depressing the wound and pushing it from opposite axis is not recommended. Rather, you need to use two instruments, one behind the nucleus and a Sinskey hook or a cystitome in front of it, and just grab it and pull it out. In this way, you can remove the nucleus through relatively smaller incision and more safely as compared to regular pull-push mechanism, depress push mechanism. These are various options for nucleus removal. So what is mandatory for anterior segment surgeon? We have already mentioned it. Metal spatula is inserted through pars plana or through the incision. Then clear vitreous and cortex from the AC and try to preserve as much of the posterior capsule or remnants of the anterior capsule as possible. That is mandatory for anterior segment surgeon to give as clear and quiet anterior segment as possible. That will facilitate proper clinical examination and decision making in postoperative period. And the optional thing is intraocular lens implantation. If you are sure about the capsular support and you have cleared the anterior segment of all the remnants of the lens matter, then you can safely implant the intraocular lens. It is not contraindicated because the nucleus can be removed through the posterior approach by the vitreoretinal surgeons. But this is optional. Many surgeons will leave it aphakic for secondary implantation. Timing we have already discussed, that is 2 to 4 weeks if possible. And we can continue Phaco if it is a small fragment and it can be levitated into the anterior chamber and emulsified. If it is a large segment and it has gone too far posteriorly, it's better to leave it there, or it's better to convert. If the whole nucleus is tilting or descending, then you can enlarge your incision and remove the nucleus by the technique which we will see again in the following video. Compartmentalization is essential and you can use OVD to keep on providing cushion between the anterior chamber and the posterior chamber. And you can keep on emulsifying segment by segment against the cushion of viscoelastic in cases of small rents and small nuclear fragments. Use minimal phaco power, low vacuum and low aspiration flow rate, that is known as slow motion phaco. In cases of large capsular rupture, the phaco needs to be abandoned and the nucleus needs to be removed in toto, and you can convert it into extracapsular cataract extraction. What is slow motion phaco? Moderate vacuum, low flow, and just adequate flow to keep your anterior chamber form. And excessive use of viscoelastic is a part of the technique of slow motion phaco technique. Wherever there is zonular compromise, slow motion phaco is indicated. How to convert to ACCCE? Simply enlarge your incision according to the size of the nucleus or nuclear fragment. Bring it into the anterior chamber and pull it out of the eye by placing a smart instrument behind the nucleus and a Sinskey hook or the capsulotomy needle in front of it. Just pull it out of the eye. And if you have already divided it, then you can pull the nuclear fragments out of the eye one by one. That is a kind of modified small incision cataract extraction.
Bismillahirrahmanirrahim. In this video, we are going to discuss management of complications of phaco surgery. We will be discussing management of rupture of posterior capsule before phaco emulsification and removal of nucleus the rent occurs. And I'm going to show you my approach, one of my approaches to manage this difficult situation. Posterior capsular rent has been noticed. It has prolapsed in the anterior chamber. So the phaco was abandoned. Viscoelastic is being injected into the anterior chamber, anterior to the nucleus, as well as posterior to the nucleus. And then pull-push technique is being used to express the nucleus out, which was only partially successful in this case. So I modified the technique and pulled the nucleus out, inserting the y-axis behind the nucleus and a length dialer anterior to it. Point to note here is that the conventional method of expressing the nucleus by depressing the incision lip and applying the pressure at opposite axis is not advisable in these scenarios because it distorts anterior segment and exposes the already rendered posterior capsule to further risk. After removal of the nuclear fragments, anterior vitrectomy is being performed. First, we clear the anterior chamber of all the prolapse vitreous. I always prefer two-port method and take irrigation line separately in my other hand. After gradual gentle clearance of the prolapse vitreous from anterior chamber, the tip of the cutter is dipped down through the rent behind the posterior capsule. At the same time, remnants of the cortical matter are also gently cut and aspirated out of anterior chamber. And generally, I prefer to sweep along the pupillary margins at completion of my anterior vitrectomy to make sure that there are no vitreous tags distorting the pupil and prolapsing into the incision. Thorough anterior vitrectomy is completed. And a very delicate balance is established between irrigation line and the vacuum settings so that anterior chamber doesn't collapse during the procedure, which may be lethal to the remnants of the capsular bag. Sometimes a scissor can be used to excise the vitreous tags from the incision. Viscoelastic is injected into the anterior chamber and especially is used to create space between posterior capsule and undersurface of the iris. In all the quadrants. Moreover, this maneuver assures about intactness of the remaining capsular bag all around. A 6.5 millimeter PMMA single piece IOL with 13.5 millimeters overall diameter was selected in this case. And preferable method here is bimanual insertion technique so that there is no extra pressure on the zonules or rented posterior capsule. And we make sure that the haptics of the intraocular lens are placed away from the rented capsule. So once the centration of the IOL is assured, we immediately proceed to closure of the wound. N0 nylon single cross suture is applied. The suture is trimmed short and the knot is buried. One needs to be very gentle while applying the knot. These eyes are hypotenuse and extra tight suture may result in a fairly high amount of astigmatism. So a very gentle, secure knot is applied, the suture is cut, and viscoelastic is removed with the help of irrigation aspiration cannula from the anterior chamber, and you can very well realize that the IOL remains well centered. And if IOL remains centered during this irrigation aspiration maneuver, it will remain centered in the postoperative period as well. Thank you very much for your kind attention.
So any comments about this video? So this is another case in which was referred to me with the dislocated nuclear fragment in anterior chamber, and the visual axis is all blocked with the presence of the lens matter. And I was in favor of deferring it, but after discussing with my fellow colleague, we realized that this nuclear fragment is damaging the corneal endothelium. So instead, in spite of the compromised cornea, we intervened within 1 week of initial surgery. And as you see, I have injected a little adrenaline and then the visco is there. I'm just feeling the situation at this stage and planning my intervention accordingly. I have removed the suture which was placed by the previous surgeon. And now the Simcoe cannula goes in a very slow IA mode, just drop by drop. And again, the lesson here is keep the chamber formed. Most of the fluffy matter was removed, but the part of the nuclear fragment could not be removed, which I used by manual technique. I engaged the fragment into the Simcoe tip and then kept on pushing it with my other instrument. After clearing the anterior part of the pupil, I removed the fluffy lens matter from the undersurface of the iris. And remember, no intraocular lens has been implanted in this situation. Now at this stage, I realized that further manipulation will be damaging. So before attending the rest of the lens matter, I perform the anterior vitrectomy, which is again by manual. Irrigation line in one hand and the cutter in other hand. After removal of this fluffy lens matter and the nuclear fragment, the view is relatively getting clear. So I was just thinking and relaxing and planning again at this stage that what should we do now. So one of my assistants suggested, sir, use pupil hooks before planning it any further, because only that will clear the situation. It was getting very difficult for me and I took his advice, inserted the chamber maintainer and fashioned the stab incisions for placement of the pupillary hooks. You can use a side entry blade or MBR blade ideally for placement of these hooks with lobes. So after dilating the pupil with the help of pupillary hooks, the plan became relatively easy. There was some residual lens matter, but luckily the superior half, rather supratemporal half of the posterior capsule was found to be intact. So immediately we decided to tuck the inferior haptic and we will use the remaining capsular support in our favor. And after planning it carefully for placement of the inferior haptic into the sclera, I removed the inferior hook because the lens matter and everything was now clear. Axis of multi-piece intraocular lens is injected into the anterior chamber through the pre-placed phaco incision by our previous surgeon. So again, a little thinking was involved because in these situations, you are dialing the haptic anti-clockwise. You will see after tucking the lens haptic, you have to dial it in opposite direction. So that's why I placed it under the iris and then brought the other haptic out through the incision with the help of two Sinskey hooks, one behind the IOL haptic, one in front of it. And this is my own modification in Yamane's technique, that is, and then thread it into the 30 gauge or 27 gauge needle to take it out through the tucking site. Here is the 27 gauge needle, which first has gone tangentially into the sclera, 1 millimeter behind the limbus, and then is directed posteriorly towards the center of the vitreous cavity, and ultimately the needle is retrieved with the help of visco cannula through the IOL of phaco incision outside the eye, and the other haptic of the intraocular lens is already lying there. So we are threading the intraocular lens haptic into the 27 gauge needle with the help of a straight suture tire or McPherson's forceps. After threading, we need to be gentle in this whole maneuver because you can very easily damage the IOL haptic. The haptic is now externalized through the fixation site or tucking site 1 millimeter behind the limbus, and after a little manipulation I retrieved the other haptic anteriorly and placed it into the shelf, that is the space between back surface of the iris and remaining half of the posterior capsule. And then this IOL haptic end, which was externalized through the tucking site, a heated squint hook is used to change the haptic end into a bulb, and the haptic is tucked into a pre-placed cut in the sclera. That cut is just at the limbus. So without any sutures, the haptic is tucked in sclera. The chamber is formed and no sutures are needed. The placement of sutures in the end depends on the maintenance of the anterior chamber and the quality of the wound itself. The patient, alhamdulillah, responded well and now is about 612, about 2 weeks post-operatively with well-centered intraocular lens. There is another case which was referred with dislocated intraocular lens and part of the nucleus into the vitreous cavity. As you can see, there is intact capsule here. The PC rent is there inferiorly, and here is the pseudophacos lying on the retinal surface along with fluffy lens matter and fragments of the nucleus. So we decided pars plana vitrectomy.
Bismillahirrahmanirrahim. Dear viewers, in this video presentation, I'm going to explain PPV with dislocated PCIOL exchange and single haptic scleral fixation of PCIOL. The video was edited and produced at Wabra Teaching Hospital Complex, Lahore, Pakistan. The author carries no financial interest in this video. These are the pre-op pictures. We identified 3 problems. 1, infranasal PC rent. 2, scattered nuclear and cortical lens fragments. And 3, dislocated wandering PCIOL was noticed lying on inferior retinal surface. The surgical video follows. First of all, we decided to strengthen the pre-placed IOL incision site, and then routine preparation of the 3-port pars plana vitrectomy is underway, and irrigation cannula as per routine is going to be placed first. Here it comes. The irrigation was turned on and then turned off, and it is secured in place with the help of pre-placed stay suture. And similar kind of stay sutures are to be placed in supratemporal and supranasal quadrant as well. So then the ring is being tied for placement of the contact lens. Anterior chamber is being cleared of the remnants of the lens matter with the help of Simcoe irrigation cannula, and then viscoelastic is injected into the anterior chamber, and we proceed with the vitrectomy under microscope for the anterior part of the vitreous, and through the rent, anterior vitrectomy is underway. And while performing vitrectomy, we realized that the pseudophacos was already floating in mid-vitreous cavity, and the margin of the lens became visible in the visual axis. So we altered our plane and decided to remove this wandering pseudophacos first. So we removed the ring, and here you can appreciate more clearly the intactness of the capsule supratemporally and the wandering PCIOL lying infranasally. So bimanual technique is going to be used to grab and retrieve the IOL. Once the intravitreal forceps got hold of haptic optic junction, the pre-placed sutures were cut and removed, and the wound was enlarged for easy and safe delivery of the optic of the IOL. And with the handshake technique, the pseudophacos is removed once it goes out. So the sigh of relief is there, and remnants of the vitreous and cortical matter are being cleared first anteriorly, and you can realize that supratemporally the capsule is intact, and infranasally the capsule is lacking. So we decide to fixate one of the IOL haptics infranasally, and thus partial thickness scleral flap is prepared and straight Brownian needle is passed 1 millimeter behind the limbus, directed toward the center of the vitreous cavity, and then redirected anteriorly and retrieved through the IOL incision with the help of a viscocannula acting as a spatula. And then the nut is being secured at the point of maximum convexity on the haptic of the IOL, and the tied haptic is placed first behind the iris and is dialed in position by applying gentle traction on the fixation suture, while the superior haptic is going to be placed on remnants of the posterior capsule supratemporally with the help of a dialer. Once the position and centration of the IOL is assured, the fixation suture knot is tied beneath partial thickness scleral flap by recurving the needle and taking partial thickness bite, and the suture is tied to itself and secure 3-1-1-1 knot is applied and the ends are trimmed short. And now we readdress the remaining part of our post-planar vitrectomy. The lens is in place and bimanual post-planar vitrectomy is performed, and you can notice the remnants of the lens fragments lying in front of the disc. Once this whole vitreous and the cortical matter is cleared up, the ports are closed with the help of pre-placed sutures, and in the end, the irrigation port for irrigation.
This technique may appear a little old-fashioned now because we are using the sutureless vitrectomies, but the basic concept remains the same. And the more complicated the challenge is, the different approaches may be there, the more controversies it gives rise to. So here is another issue which was created by my own self. I saw a video that we can use the axis of multi-piece as a scaffold for phacoemulsification of dislocated lenses. So I decided to try it. I brought this fully dislocated, only partially supported nucleus, which was morphinide in the anterior chamber. And after injecting the viscoelastic in front and behind of the nucleus, bringing it in front of the iris, it was a relatively microspheric hypermature lens. Performed a little vitrectomy behind it to create space and injected the axis of multi-piece intraocular lens behind the nucleus in front of the iris. And the intention was to create a kind of pseudo-anterior chamber for slow motion phaco. But the dream never came true and a very drastic accident occurred. And because it was a challenge, so we already were recording it. That's why all the events were recorded. I had planned it for my first haptic tucking as well. This was my first haptic tucking of modified Jumanes technique. So the lens is here. I was able to place it on the iris. And the judicious use was viscoelastic was there to keep on providing the cushion to corneal endothelium. After positioning the lens, the nucleus is right there. It's a rather full lens. The moment I take the phaco in, this is what occurred. The lens tilted and the nucleus descended. And so descended my heart into my knees. So I immediately attended the pseudophaco's first so that we don't have two dislocations into the vitreous. He was about 52 years age man. So the vitreous was relatively liquefied already. So I removed the pseudophacos and then did some wrong tactics to bring the capsule, the dislocated nucleus back, which are not recommended actually. But ultimately, I diverted my attention, as I have mentioned, for clearance of the anterior chamber first. So I cleaned everything and then inserted the chamber maintainer. And here is, we have the arrangements of all posterior segment tissues as well. So I immediately took the biome and had the view of the posterior segment. And then 23 gauge sutureless vitrectomy was planned, which was again modified because the vitreous was quite liquefied and already PVD was there. So we just used 2 ports, and we did not go for the irrigation line in this case. We decided to use same AC maintainer as irrigation line. And after establishing the 2 ports on the sides, here is the nucleus lying on the posterior pole. Because it was not only nucleus but the full length, so anterior capsule was there. So that fact actually helped us just to engage it with the vacuum of the vitreous cutter and pull it anteriorly without using perfluorocarbon or endocryoprobe. Once brought in the anterior chamber, the assistant supported it with the Sinskey hook. The pre-placed sutures were removed, and here goes wire vectors. And as I mentioned, it is being pulled out from the anterior chamber against the AC maintainer gives you a lot of cushion. You can control the intraocular pressure with your foot control. And after removing the nucleus, I decided to carry on with my plan of haptic tucking. And the axis of multi-piece lens is here. I have marked the axis of the haptics to be tucked 180 degrees away from each other with the help of a toric marker, or a straight needle can be used. Then 27 gauge needle goes into the sclera transconjunctivally, and first it goes tangentially, then it is directed posteriorly into the eye and is retrieved through the IOL incision. We feed the IOL haptic into the needle, and then as the needle takes the IOL haptic into the eye, at the same time I push the intraocular lens through the same pre-placed incision which we use to remove the nucleus, and the one IOL haptic is threaded. I use the cautery to change the haptic end into the bulb, but that was not very effective. So you will see later that we are going to use the heated squint hook to get the same desired effect. The other needle goes from the other tucking or fixation site into the eye and then is retrieved through the incision outside the eye, and the other IOL haptic is being fed into the needle with the help of a straight suture tire or McPherson's forceps, and the other haptic is also retrieved out 1 millimeter behind the limbus transconjunctivally. Both the haptic ends are transformed into bulbs, and you will be seeing this technique again as we have a dedicated segment to haptic externalization and scleral fixation techniques, in which we will be reviewing the whole international techniques being exercised in these situations along with my own innovations. So we have a dedicated lecture which will be we will be discussing the haptic externalization and scleral fixation and tucking techniques. So conclusion is again the same. Effectively dealing with the crisis is a matter of having prepared for it. Be ready for intraoperative modifications of the plan. Remnants of the posterior capsular support need to be preserved and utilized to the maximum extent for safe outcomes. Thank you very much for your attention. So any